All right. Well, thank you, Orazio. It's lovely to have you here. So Orazio is an old friend of ours. We have funded Orazio for 2 years, and in 17 and 18, also last year. And then this year, his extension grant is generously funded by the Melissa Lewis Foundation as well. Uh, Orazio is at UNSW at the Lowy Cancer Research Centre, and he's the team leader for metal targeted therapy and immunology. Orazio is also a project leader at Children's Cancer Institute. And excitingly, in 2020, he was awarded the New South Wales Premier's Award for Outstanding Cancer Research. And actually, last year, I was lucky enough to see him receive the New South Wales Young Tall Poppy Award in recognition for his cancer research as well. We are delighted to have Orazio here. Today, we'll be talking about his work on neuroblastoma and glioblastoma. Neuroblastoma accounts for 15% of total childhood cancer deaths. And sadly, glioblastoma had the worst survival rate of all cancers, with only 20% of those diagnosed living longer than 5 years. As many of you are aware, Orazio has recently announced significant breakthroughs, of which I know he is, but we are incredibly proud as well. And we will be touching on some of that later. Just cognizant there's a lot of this is still under wraps, so there's certain things that he won't be able to share with us as well. So welcome, Orazio. It's great to have you here.
Thanks, Nikki, and thanks to all the people in the audience. I feel like I am more thankful, and very happy to be here because I feel like you guys are part of my team, because you are. Without having your support, we couldn't achieve what we've done so far. And it's fantastic working together in this and see now approaching the time where we actually can impact the life of these kids. It's really exciting, really exciting. Thank you so much.
Yeah, our pleasure. We love working with you too, Orazio. So before we talk about your research, you have a very interesting story as to how you ended up in cancer research. And do you want to share that with the audience?
Yeah, I was a PhD student in 2009. It was a Friday afternoon, 3 p.m. One of my colleagues who was working in the imaging department asked me to try a new ultrasound machine. And basically, it saved my life. He found a kidney tumor, just early stage. And I got the operation. I went to follow up for almost now 10 years. And I'm happy to say that I'm clear. But this changed completely my perspective of life. And also, I was engaged at the time. I got married the year after. And the first things, me and my wife wanted to have children. So I was thinking about how it's terrible, when a family has a little child and receive this terrible news, their child has cancer. So I decided to dedicate my life to work on this type of tumors, because they are considered as well rare tumors. There are not many people who work in this area, and there are not many funding in this area. So I did decide to do something about that and have an impact on the life of these kids fighting, with these terrible diseases.
Yeah, look, absolutely. It's very powerful, not only for you to have a cancer diagnosis, but also, now to be helping children who have the same situation. So thank you for what you do. Let's move to kind of a high level before we get into your research now, but about neuroblastoma and glioblastoma. Do you want to explain a little bit about those tumors and why they're so difficult to diagnose?
So it's very difficult at first to diagnose those tumors because kids are very young. Some of them, they are younger than 1 year old when they show some symptoms, but parents don't know, they cannot recognize about that. Even, GPs or doctors, they cannot recognize about that. And it's very difficult to do imaging. Like, when you talk about having a CT scan or an MRI, it's very difficult to have those kids, under those kind of machine. They need full anesthesia and so on. So unfortunately, the majority of these tumors are diagnosed very late stage, and they are very aggressive. They develop very fast. And both tumors, neuroblastoma and aggreglioma, they are tumors that actually they originate by mutations. So what do we mean mutation? When kids, unfortunately, they born with a mutation in their genes, they can, for example, have one thing, some mutations, they don't have 5 fingers in a hand, they have 4. And similarly, there are some mutations who can generate cancer. Like in the case of neuroblastoma, we have found that there is a gene which is called MECAN that causes these tumors in those kids. Or, for example, in hyperglioma, like the IPG, there is this modification, a histone, that causes this tumor. So unfortunately, it's very difficult to diagnose, and it's very difficult to treat those diseases. On the other side, for example, these kids, they undergo to massive and very aggressive therapies, chemo, radiation, and unfortunately, some of them, they don't survive because as well of the, so aggressive chemotherapies. Unfortunately, this is the only way we have to save the life of the 15%, for example, of kids we save for neuroblastoma, or give a little bit more time for kids with glioblastoma. So the idea of our research is actually study new therapies that do not also increase the side effect and the difficulty that those kids they undergo during the treatments as well.
Yeah, look, it's a common theme, and we've spoken to Dr. Vanessa Chin last week and Kate Van Dyke the week before, and in their different types of cancer research, they talk about the significant ongoing impact of the treatment plan has on and the side effects it has on patients. We talk about chemotherapy on kids. It affects their heart, it stunts their growth, it affects their brain. So significant impacts on these little kids, as you say, less than a year old. So the situation now, if we had a child that was diagnosed with neuroblastoma, what's the current situation? What's the treatment plan that they go through today in 2022?
Unfortunately, we're still using chemotherapies which are made in the 60s. And most of them, they were made for adults. It's been, I think, only 1 or 2 chemotherapy have been approved specifically for children in the history of the oncology discoveries, which it is strange because kids are different than adults. Even the metabolism, the growth rate. So these kids, they go in what they call it induction therapy, where they have massive immunotherapy cycles. Then they have radiation, surgery most of the time to try to reduce the tumor mass. And then again, they go under follow-up. And unfortunately, the majority of them, they relapse. And when they relapse, it's the difficult phase because it means that the therapies are not working anymore. The tumor relapse because the therapies are not able to clear the body from the nasty cells. So at this stage, nowadays, for example, for neuroblastoma, we are using this immunotherapy. It's called anti-GD2. So what the immunotherapy does, try to wake up your own immune system and fight back the tumor. Sort of, let's say, vaccine way to work, right? So like, fighting the flu or even coronavirus nowadays with a vaccine. So you boost your immune system against the tumor. The problem is that the tumor is really, I would say, mean. So he hides from the immune system. He always change. It looks like really difficult to catch for the immune system. And what we found out was that one way that the tumor used to hide for the immune system is building this shield of copper around. And when we can open a door in this shield, the immune system can see the tumor and kill it, and kill the tumor cells. So our idea is, and nowadays this immunotherapy is working only in 10% of the patient. So these are the patients who, unfortunately, they're gonna have a very poor prognosis. They're gonna die probably in 1 year, even less. if the immunotherapy doesn't work. So what we have seen with our studies, we are almost ready to go out with a new publication, is that when we combine the co-pegylation therapy with the current immunotherapy, we are able to have a better effect to this drug. Around 60% of mice in this way, in this of the model disease, they become clear completely. From the other side, the other tumor, which is high-grade glioma, is more aggressive and is in the brain. So a very difficult location. The majority of the therapy don't reach the brain. And when they do reach the brain, the risk of damaging such an important organ for the functional life of kids is so risky. So we have been dosing the drug as well, and we have been having very nice effect in the animal model. So these are kids basically who they almost in 5 years, 6 years time, all of them they're gonna die. So there's zero almost survival rate. The data we have is that we improve the survival about 25% in our model, which is great for a tumor so aggressive. So our hope is to bring this co-pegylated agent in the clinic in combination with the drug they're using, because we know that there's a beneficial effect. And how we're going to do this? So specifically, we decided to work with the not new drugs, because put in the market a new drug that we could develop. We have a new drug we develop, but it would take 17 years, which means go through all the regulation, approval, and so on, which means lose too many lives. So if we can go earlier in clinical trials, we can have an impact earlier and save more kids in Australia and worldwide. So we're using a drug which is used since 20 years already in children with Wilson disease. It's a safe drug, very low toxicity, is oral as well, so the kids can drink it, which is fantastic, because the majority of the kids, because of the treatment, they have all their veins completely ruined. Another injection is painful, is another problem. The kids actually can swallow the drug with the water at home. So we thought specifically about using a drug which is already there, approved in Australia. So it's in our TGA, and I know they are trying to go in the PBS to make the drug available and free for patients. So we are working very close with this pharma company now to go and ahead with this step.
That's brilliant. And we'll talk about what you're doing there in a second, but let's just take a step back, and you talk about copper chelation therapy. So we've got young kids who have currently, particularly glioblastoma, 0% of survival over 5 years, which is horrific, hard to diagnose and hard to treat. And you've got this tumor that's incredibly smart and it's hiding from the treatment. Now, how did you discover this therapy in regards to copper, and what impact does the copper, for the people that are new here, what impact does the copper have on that tumor?
So we discovered, it was a little bit of serendipity in reality, because I had a tumor model in my lab which was resistant to chemotherapy, and I couldn't understand. I was trying to understand what makes this tumor so strong. And one of the things, you analyze protein, analyze genes, but one of the things we found as a constant of all the type of tumors resistant to therapy was high level of copper. So 6 times high level of copper compared to the normal cells. I was trying to understand why, and slowly I started digging in the direction. I understand that copper is important for the metabolism of the cells. So it looks like it works like petrol for the metabolism of cells. So cancer cells, they need to speed up. They need to speed up very fast. And they need more copper for this reason. And they need more copper for recalled blood cells, so they can make blood coming there and bring in nutrients in the tumor. So we go step by step. We publish the first paper about the energy. We publish the first paper about the angiogenesis. In the meantime, other people were working in the same field, and there was a paper coming from Switzerland about lung cancer and copper, showing that the mouse with lung cancer, when they had high level of copper in the water, they were doing poorly. Like, the tumor was spreading faster, was growing faster. In the meantime, another team in US discovered that breast cancer is highly dependent on copper, and they're actually running now the clinical trials phase 3. The good thing is we start talking together, and we share data, we share the model and so on, and we are discovering then this dependency of copper in general in many tumors. We are now analyzed about more than 200 types of tumors in patients using bioinformatics. All of them, we found a sort of dependency of copper. So it looks like copper is like water for the tumor. But our team made this difference, discovering the effect on the immune system. So our breakthrough was about this. We were the first one telling people, look, the tumor uses copper as well to like a shield to hide from the immune system.
So you've got this really smart tumor that's bringing in copper, and it's using it to grow and grow. And copper naturally exists in all of us, but it's clever and it's growing. How do you, and you talk about using existing drugs, a combination of existing drugs, how do you break down that shield and get into the tumor to start treating that effectively?
So there are some people with a rare disease, it's called Wilson disease, that for some reason, genetic reason, they accumulate copper in the liver and in the brain, and they're born with this disease. But they manage to clear the body from the excess of copper using these drugs, which are called copper chelators, like trientine, for example. And what's happening is, in fact, if they're not treated early, the patient gets liver cancer, which is going to tell you something about, the excess of copper pushing this growth of the tumor. So our idea is use exactly the same drugs that they're using to clear the liver and the brain for the excess of copper, but to clear the copper from the tumor. And what does that drug does? The drug has a very high affinity for copper. So once it is in your body, the drug is gonna go and look for copper until it touch copper. And once the drug is bound on the copper inside your body, the drug is gonna clear the copper out through the urines, for example. And this drug are very well, first well tolerated, but also well studied. We have pharmacokinetic toxicity profile already done. It's something that we don't need to do anymore for get the approval to go in the patient, which saves us lots of time.
That's amazing. So once they have that drug in their body, does that always stay there? Would it be right to say that it stops the copper all of the time, or do you have to give that drug every so often to increase those levels?
This is a great question. So people with Wilson disease, of course, they keep accumulating copper in their body. So the drug has a half-life, which means gets degraded in our body in about 9 hours. So these people drink this drug 3 times a day for the rest of their life. Mm-hmm. And the good news is that they don't have toxicity. They don't have side effect. No loss of hair, no heart disease, no kidney disease. This is fantastic. So what we want to do is, we think is, in reality, how these people with Wilson disease have this copper accumulation in the liver, the tumor represent a sort of Wilson disease in our oncology patients. So the idea is giving the drug every day, because the drug gets cleared faster. And once the tumor disappears, stop with the drug, so that we follow up and see what's going on. And we are modulating this as well in our mouse model. What's up is that we treat the mouse, you see the tumor completely disappear, which is fantastic. This is always an emotion to see, I know it's a mouse model, but when we see a tumor, they're gonna kill the mice in 15 days. Having a mouse for 200 days clear of the tumor, it is fantastic. Because we made it here. So we follow up the mouse until, we can, on the base of the lifespan of the mouse to see if the tumor can come back. Because what we want is also avoid the recurrence of the tumor.
So you've made this discovery. Then you've also discovered that using existing medicine in combination in a way that is effective for kids, that doesn't impact their ongoing lifespan should they survive past these tumors, and in an oral way that they can drink it rather than have to have it injected. So you're talking about 3 or 4 different levels of treatment here and discoveries, which is absolutely phenomenal. Last year, you talked about the impact on the mice model and the copulation therapy on that. For those that aren't aware, why do we use mice in cancer research?
So it's really important to use mouse in cancer research, mouse model. I know it's sad because it's an animal model. All these mice are generated in the lab. They are not wild mice. They've never seen the wildlife before, but they have the same mutations. They have the kids. So the mouse born with the tumor, like the kid, and the tumor evolve in terms of spreading, growing the same way. And we know that these models are very good in showing when the tumor does not respond to therapy. On the other side, because our drugs, they works activating the immune system, we need to work with a live mouse that has an immune system. We cannot mimic this in a plastic tube because you have the immune system there. So you need a full body, active and healthy full body, try to fight the tumor. So it's really, really important to have the mouse, and especially for the toxicity, because usually what is toxic in the mouse is going to kill a child. So you don't want to have this. You want to dose it properly and be prepared that whatever you test cannot harm, the kids more, than what they already go through.
So in the mice models, we're seeing this therapy work to, one, increase the lifespan of the mice, and then in some cases, the tumor disappears entirely for as long as the mouse is alive.
Currently, with our combination with the immunotherapy, usually the immunotherapy alone, the tumor disappears only in 10% of the mice. With our combination, we have 60% of the mice without tumor anymore, completely clear. Wow. That we move from 15 days of life with tumor, so they die after 15 days. We are now at 118 days today, and they're still clear. So we're trying to monitor how is the situation.
I mean, just to think about that, that's incredible. So obviously the mice aren't children, and we know that, but to have such positive and strong results that these tumors, which kill kids in 100% of the cases, is having a positive effect on mice with the tumor is phenomenal. So where do we go now? Obviously, we've got an extension funding for you. You've made these breakthroughs, you've made these discoveries. What's the next step? What do you need to do now?
So as I mentioned before, we contacted the pharma companies involved with the drugs. I cannot tell you specifically what we've been talking about, but they're happy and excited as well. In a sense, they want to work with us, and we are working together. So we sign agreements with this pharma company. So what we are moving forward is we wrote a protocol in collaboration with clinicians at the Seed and Children Hospital. So we are moving forward towards the trial. So the trial is going to go through different steps. So now we have the protocol. We're going to go to get the human ethics approval as well. And also we are trying to write another grant. It's going to be the MRFF grant for supporting the hospital cost. We don't want the kids and the family to pay anything. There is no IP in this protocol at all. So the pharma company at the moment, what they're going to do is mixing together the drugs and giving the drugs for free to the kids. We are talking about, because I would say we are lucky enough that this is a rare disease. So we have a few kids in Australia, diagnosed, which is going to be about 20. And probably we're going to need to go internationally as well. So we are talking with the people in Spain, in UK, and Germany to expand the trial in there, because there are already trial in there working with similar approaches. So to get more number to be statistically significant, because when you go to the FDA, you need to have bigger number to show that the drug is working. So we're going step by step, mostly regulation. I want to just tell people that it really touched me, something that the CEO or one of the pharma companies said. The pharma company doesn't work in the cancer area, works in the other areas, but they produce the drug we're interested with. And they say, this is such a terrible disease. As a father of 4 kids, I will help you no matter what. So it was really, really good. And when people describe the pharma company as, they're angry and difficult, and greedy people, it's not always like that. Of course, there is marketing there, but without them actually as well, we could not go ahead with the trial.
I mean, this is incredibly generous of them, absolutely, but also very exciting that we've got 2 forms of cancer, one that has 0 survival rate after 5 years, that you're on the verge of a clinical trial with kids here in Australia and in Sydney as well. We've been lucky enough to fund you for 4 years now. Can you just talk a bit to the audience about how important that early career funding is for you and your colleagues?
It's vital. It's not all important. And I tell you why. In 2016, when I applied and I got it in 2017, when we noticed first this dependence of copper in the tumor, I found very strong, let's say, diffidence from my senior colleague. You're talking about metals, you're talking about copper, no genes. No, your idea is crazy. We're not going to help you. We're not going to support you. And I was almost giving up to the project. But I submitted the project to Q Cancer Australia, and it was supported from them. It gave me, it's not only the money support, but also psychological support to go ahead, to tell me I was going in the right direction. And only when the international people start looking at it as well and publish the first paper, then people in Australia start believing me as well. So it was vital, because I was almost to give up and I wouldn't reach this point without the support. So Q Cancer Australia, it's fundamental for young investigators with new ideas. What we have nowadays with NHMRC Ideas Grant is not helping young investigators with new ideas. Even if it's called Ideas Grant, they are still judging the grants in the old ways. So Q Cancer is actually one of the few supporters of really new ideas in Australia.
Thank you. And you and I have talked about this personally before, but I hope I'm not misquoting you here, but you have a team there, and you've talked to me about how you spent probably 80% of your time rather than doing the research. You're applying for the funding so you can carry on doing this research.
Exactly. Unfortunately, we spend lots of time trying to find the funding for the research. And the balance is very difficult, especially in Australia in the current situation. It would be better to focus our energy in the lab work, actually, and the actual research for this. But this is the current situation. What I'm trying to teach my team, I have 3 postdocs, all 3 are female, or 3 have families with kids. I tell them, we have to try to balance, both the lab work and also the writing work to get the support we need. We have now working, of course, in other ideas, we other drugs, other challenging tumor as well. So we have more stuff, that we can offer to people with cancer, and also different cancer as well. We're working in breast cancer, with our collaborators in US to helping them with the trial going on, because it's very exciting, helping mothers as well, which is great. So the system needs to change. And especially for us, we feel this pressure that, our job is not safe and it's difficult. However, I think supporters and funding like Q Cancer Australia give us hope. And I hope if Q Cancer Australia is going to keep supporting young investigators. I mean, I'm already old enough to tell you that I have 3 fantastic, postdoc with their own ideas. They want to, go ahead, and I'm very supportive of them. And I think, I always take Cancer Australia as an example of the good way to support research with them. So I think you guys are doing a great work, not only for science itself, but for science and scientists in this country. Something that should be more a knowledge outside. Because of you, there are scientists who are not leaving the country, who are not leaving the job, that can really have an impact in the life of Australian people, but also worldwide. And it has to be recognized at the government level.
Yeah, thank you. I mean, I think that's really important. You talk about your collaborations around the world and with this copper chelation therapy for other types of cancer, and that's something, in the corporate world you're not used to, that people in research share their knowledge and share their ideas to help solve this problem. So you've got this amazing clinical trial just about to happen. Obviously, you need to make sure the numbers are statistically valid as well. Where do you see this going? What is your hope for the future as you continue your research?
So the clinical trials, it takes time to evolve it. So, and they go from the phase 1, phase 2, and phase 3. So I would say that the evolution that I hope is that this copper chelation therapy is going to be recognized as one of the frontline therapies, which means the kids, once they get diagnosed with the disease, they're going to use this drug for them as a normal drug, the drug that they would recommend. For reaching this stage, you need time and different stage of the clinical trial, for sure. And usually it will take each phase between 2 and 3 years. So there are 3 phases. So we are still at least between 6 years and 9 years far of the drug becoming, the drug that any clinician can recommend. However, starting already from hopefully next year, when the trial is going to get up, we're going to save, we could save life of the children with this disease.
Yeah, it's phenomenal. It really is. And I think, you don't play it up enough, but the work you and your team have done to get to this stage with all these discoveries is life-changing. And, sadly, it is a life sentence for the kids at the moment. But hopefully one day, not only would they be able to live longer lives, but lives that are better because the treatment isn't impacting them the way the existing treatment is currently. So congratulations again to you and your team there, Orazio. The life of a researcher is tough. You've got a largish young family to look after, planting imminently. But what motivates you? What keeps you doing this?
That's a very good question. So, as you mentioned, I have 3 beautiful kids, 10 years old, 7 years old, and 20 months old. And my wife works full time as well. So she's amazing. It's tough when people say, work-life balance. I would say if a scientist tell you that they can keep a work and life balance, most of the time they lie. So it's the work is embedded in my life in a sense that, for example, if I go and see the soccer match of my son on Saturday morning at 9 a.m., probably you will see me with the laptop, sitting there, watching him on the other side, analyzing some data, because I want the data before Monday, ready to share with the team and move on with the other experiments. I do this because I really like science. I think discovering more knowledge, understanding more of the human nature and our biology will solve many problems, not only in cancer but in many other diseases. You will be surprised that I've been contacted by people working at Alzheimer and Parkinson, because copper is involved in those diseases too, to see if I can give them some help in some way. So I think science is fascinating and I really love it. When uh, it looks like when I have some results, some experiments, I want to go to the end of it. It's like when you read a nice book and you just, look forward to see what's happening after, and this is really, really what drives me a lot. And my family feel it. My kids know what is a gene, like even my 6 years old knows what is a gene, what is DNA. They come in the lab. They really know what's happening in my life. I don't keep them away. And my wife has been super supportive. She keeps saying to people, never married a scientist. But but I have to say, if I am also where I am, it's also because I have a great support at home. And I took paternity leave last year when our 20 months old baby was born, because she was in a career time where she need to step up. And I decided to slow down for 6 months, which is a lot of time for a researcher, and look after my daughter, because I thought it was fair to give back what my wife was giving back to me with our previous two kids as well. And they worked beautifully for both of us.
Yeah, no, it's lovely. So what can we do? You have the team here, we've got some of our observers and some of our board. What more can we do to help support you?
Uh, what I recommend is that you do exactly what they're doing, because you are helping new ideas, you are helping new people, you are helping new researcher. So at my stage and where we're up to, I think now we are a level where it's about more the trial and getting the right people connected, which is family, pharma company, and clinician in there. So more you advocate for, getting resources for what they consider rare diseases, better it is. But keep doing what you're doing, because I have a team of people that they have their own ideas, they have their own little discoveries there that maybe they become bigger, and thanks to people like you, they can grow and they can become the next researcher, the next breakthrough, the next if we reach 60% with our drug, we want to reach 100%. We need to get those people help. We need to get these people help, and I think you're doing a great job in this sense. Again, supporting young researcher and new ideas is the key of success for the future.
Thanks, Orazio. And just finally, before I do a recap of today's session, where's the future for you? You talked between 6 to 9 years of clinical trial. Do you have other ideas bubbling away once you've worked out this copper chelation therapy? Are there other things that you want to do?
Of course I do. Of course I do. It's very interesting to me studying now this relationship between the tumor and the immune system. It's really a relationship. They talk to each other, they communicate in some way, and it's very interesting. I'm trying to understand their language, which is try to translate. There is always a negotiation between the tumor and the immune system, and they always talk, even when they can see each other. So trying to understand their language and convince and step in as a third mediator, convincing the immune system, don't look at it, just kill it. It's fascinating. So I want to understand more and more and more this relationship. And we found something really interesting. We are at a very early stage of this interesting conversation, because we found that basically it's like with the words, the tumor is able to say influence the mood of the immune system, if it's hungry, if it's happy or not. And understanding more about this communication is very intriguing to me.
It sounds very intriguing. Obviously, you've got a bit of work to do on that, but that's it's amazing to think that the tumor can influence the mood of the immune system.
And we think that probably there are some autoimmune disease that they work in the same way.
Yeah.
So we've been chatting with people working in immune disease like lupus, terrible disease as well. I think the knowledge we create can be expanded beyond cancer and helping people as well with other diseases.
Yeah, no, absolutely. Well, thank you very much for your time today. It's
Thank
always
you.
a pleasure to talk to you. Just to recap, Orazio and his team are looking at both neuro and glioblastoma. Neuroblastoma accounts for 15% of cancer deaths for children. Glioblastoma has a 0% survival rate really after 5 or 6 years. Your copper chelation therapy is almost at clinical trial stage, using an existing drug in a way that is easy to consume for kids, and also one that is not going to have the negative side effects that the current chemotherapy does as well. It is a pleasure to talk to you. You are saving lives around the world, and it's just an awesome concept that we are able to be part of that as well. And wouldn't it be just a wonderful day that kids are not dying from glioblastoma anymore? So thank you to what you do, Orazio, and thank you to your team as well.
Thank you, Nikki. Thank you, the team, because we are doing this together. We started a long time ago, 2017, and we are going step by step, slowly. Unfortunately, it takes time, but we're getting there, which is more important.
Absolutely, we're getting there. So thank your team again. Thank you to everyone here in the audience, and we look forward to seeing you next week. We have Dr. Yana Dathani coming along to talk about her work on prostate cancer. So thank you, everyone, and have a good afternoon. Bye-bye.
Thank you, everyone. Have a good afternoon.
See you later. Thank you. Bye-bye.